Can you hear me clearly?
Hello, guys. Hello, you guys are on mute. Good afternoon.
Yeah, good afternoon. Good afternoon. Can you all hear me?
Yeah, I can hear you. Good afternoon. A lot, I think three of you are on mute.
Good afternoon, Dr. Sarah.
I can hear.
Yeah, good afternoon. How are you doing?
This is Dr. Adewale.
Yeah, I know now.
Um,
Okay,
how is everything? Well done
we're
and
fine.
kudos for the good
Everything is
work.
good. Everything is good. I want to thank you guys. You guys are the MVPs, or you guys are the MVPs.
Well,
Okay. There's a lag. There's a lag in my audio.
Though we can hear you clearly.
but we can hear you clearly.
There's a lag on the audio. Okay.
No.
Okay, so I'm going to be off video for most of the presentation because it's going to be your show. So in a minute or so, I'm going to be off video. Panelists have control over their audio and video.
I don't seem to have control over my video.
So you can control your video and audio as you require.
I think. Um,
The live stream is up, so we can also use that when we are at capacity here.
Good afternoon. Good afternoon, panelists and all the attendees of this interactive session. My name is Dr. Olagunjo Abayomi. I'll be moderating this session. It's a session to enlighten doctors, nurses, healthcare workers, all of us generally, on the importance of glaucoma. Um, like I said, my name is Dr. Lagunjo. I'm a senior registrar in the University College Hospital, UCH Ibadan. I would like to recognize the presence of Dr. Adewale, who is the speaker today. Yeah. Okay, all right. So we would like to start with the opening remarks by the chairman of the Young Ophthalmologists Forum of Nigeria 2021 World Glaucoma Week Planning Committee. And that's Dr. Ibukun Folahan. So she'll be starting with her remarks. Over to you.
Good morning, good afternoon, everyone. I hope you can all hear me. Good afternoon, can you hear me? Good afternoon, everyone. Okay. I especially welcome you all to this program. I want to recognize the presence of the President, Young Ophthalmologists Forum of the OSN, members of the executive of the Young Ophthalmologists Forum of the OSN, hello, please. Can you hear me, please? Okay. So I welcome us all to this meeting. The World Glaucoma Week is an event held in the second week of March every year, and it shines light on that disease which silently renders millions of people blind yearly, which is glaucoma. And it emphasizes on yearly eye screening for early detection of the disease. This year's event runs from today, the 7th of March, to Saturday, the 13th of March, with the theme, "The World is Bright, Save Your Sight." Indeed, the world is bright and beautiful, and sight plays an important role in our appreciation of the world. Beyond that, it's one of the most essential senses we need for daily living. It is therefore imperative that we as health workers are not only aware of this disease, but take it seriously by getting screened for glaucoma. Beyond this, we should also act as agents to spread the news to our patients and the community. Today's lecture promises to be an interesting and illuminating one. Let us give our rapt attention and be enlightened further on glaucoma. Thank you very much. So I'll go on now to introduce our speaker for today. Is Dr. Adeyemi Timothy Adewale. He's a dynamic and trained public health ophthalmologist, a Bolter Fellow of the British Council for Prevention of Blindness 2018/2020 set, a Commonwealth Scholar, London School of Hygiene and Tropical Medicine, a Pilot Scholar 2019-2020 set in clinical ophthalmology. He's also a fellow of the West African College of Surgeons and also a fellow of the International College of Ophthalmology. He's presently the General Secretary of the Ophthalmological Society of Nigeria, Southwest Zone. He had his bachelor's degree of medicine and bachelor's of surgery in year 2007 back from the University of Lagos, and had his fellowship training in ophthalmology at the University College Hospital, Ibadan. He has a master's of surgery in clinical ophthalmology from the University of Edinburgh with a distinction grade, and also an MSc in public health for eye care from the London School of Hygiene and Tropical Medicine, also with a distinction, finished with a distinction. So you see that we have a seasoned scholar here to give us the lecture today. Let us give our rapt attention.
Good afternoon, everyone. It's my pleasure indeed to be here. I'm really honored and humbled. I count it as a privilege, and I really appreciate the organizers for inviting me to give this talk to my esteemed colleagues, senior colleagues here present. Indeed, glaucoma is a special disease, and the magnitude, the body of the disease is so enormous. It has really become a public health issue. And we as health workers, we should really take it seriously. So the full topic has been mentioned, the silent thief of sight. Why health workers should take glaucoma seriously. Okay, I'll follow this outline. For introduction, I'll briefly give the definition of glaucoma, try to explain. So I will not be technical because of the peculiarity of the audience. I'm not talking to ophthalmologists, but I still understand that we are all health professionals, and sometimes I'll use lay terms, layman's language, so that I can drive home the points. Ultimately, I'll conclude with take-home messages that we can use in our daily practice, we can apply to our daily living. By definition, glaucoma is a group of diseases that have a common endpoint with an optic neuropathy associated with characteristic structural damage to the optic nerve and associated visual dysfunction. The illustration on our right depicts what happens in glaucoma. This is just a brief illustration. You can see a depiction of the eyeball. If we understand the cranial nerves, we know the cranial nerve 2 is the optic nerve. It connects the eye to the brain. Okay, we can see the cranial nerve 2 here connects the eye to the brain, and it's an important nerve in the body. What happens in glaucoma? Uh, Here you have the vitreous humor, um, the pressure here or inside the eyeball, or I will refer to it as intraocular pressure, uh, tends to be elevated in most of the glaucomas, and there is a mechanical pressure to the optic nerve head here. That's the entrance of the optic nerve, uh, where the nerve fiber layers of the retina they coalesce together to form the retina, where they come together there. So this pressure exerts a mechanical effect that eventually leads to damage to the optic nerve, uh, what we call cupping in ophthalmology. Uh, I will show a better description of the picture there, but here we understand there is a dynamic going on inside the eye. But if you look to the front part of the eye, you have the aqueous humor here. You have the iris, the ciliary body. This is the lens. The majority of the pathology in glaucoma actually happens here, where we call the anterior chamber angle, and there is a trabecular meshwork there. Uh, it's been said that the clogging or the mechanisms that will affect the trabecular meshwork, affecting the drainage of the aqueous, that's the fluid in the eye, will ultimately lead to elevated intraocular pressure in one way or the other. Just to put it in layman's terms. So that's what glaucoma is all about. So you have all these dynamics occurring in the anterior chamber angle, um, the pressure in the eye, all leading to a common pathway. Now there are other types of glaucomas, um, but ultimately the end point is optic neuropathy, and that optic neuropathy leads to structural damage to the optic nerve, and in effect, what we see clinically is the visual dysfunction uh, that manifests. So basically, when we talk about the type of glaucoma, we talk about the drainage of the aqueous or the fluid in the eye. And you can say broadly, we have two types of glaucoma: the open angle glaucoma and the angle closure glaucoma. Uh, this illustration again is an enlarged form of the one I showed initially. This is the angle of the eye in the anterior chamber. If the angle is open and someone has glaucoma or features suggestive of glaucoma, we tend to label such a person to have an open angle glaucoma. But if there is a bunching up of the iris, the ciliary body, and that angle is narrowed or closed and affects the drainage of the aqueous through the trabecular meshwork, such a person is labeled to have an angle closure glaucoma. There are other types of glaucoma. Like I said, it's a group of diseases. There could be normal tension glaucoma. Uh, Previously, there used to be this phenomenon of a range of pressure where you can say it's normal intraocular pressure, usually between 10 and 21 millimeters of mercury. But from studies and from researches and from clinical presentations, well, we now understand that it's also possible for the intraocular pressure to be within this normal range in hope, and such a person will still have glaucoma. In such a case, such a person is found to have a normal tension glaucoma or NTG. Uh, Secondary glaucomas are glaucomas with known causes, such that if you target your treatment towards removing that cause, then you can achieve good control um, for such a glaucoma. For instance, if there is what we call uh, lens-induced glaucoma due to abnormalities in the lens of the eye, such that if you treat the cataract, for instance, if what is causing the glaucoma, then there is a release of the pressure or the pathology, that structural damage leading to obstruction in the drainage of the angle. There is also juvenile open angle glaucoma. Usually, glaucoma is found in people above 40. Uh, but sometimes you have glaucoma between the ages of 16 and you know at 30. Such a person is said to have juvenile open angle glaucoma. Also, certain glaucomas are found at birth and is labeled as congenital glaucoma. So all these have genetic undertone. There are also associated structural abnormalities in the eye that can be associated with congenital glaucoma, and it's possible to be to develop glaucoma after birth, before age 2 or before age 15. I call that congenital glaucoma. So, as been said earlier, majority of the glaucomas are primary open angle glaucomas or primary angle shot glaucomas. We rarely know the causes, and as such, they are idiopathic. Uh, but current researches in glaucoma uh, are really mapped out the genetic basis of these diseases. And so the glaucomas are either through they have been labeled primary open angle glaucoma, primary angle glaucoma, or the so-called idiopathic glaucomas. Uh, we can pinpoint a particular genetic um, factor or locus that has a defect, and as such predisposes such a person to the glaucoma. Um, Also, secondary causes, trauma, uh, a person that has had ocular trauma before, injury, blunt ocular trauma, accident, they also have a tendency to develop glaucoma. Um, uh, Also, patients or individuals using eye drops containing steroids can also develop glaucoma. So, who is at risk of glaucoma? For primary open angle glaucoma, uh, individuals age above 40 are particularly at risk. Persons with family history of glaucoma, especially first degree relatives, are very much at risk of glaucoma. So what we're saying is if someone has been diagnosed to have glaucoma, family members, especially first degree relatives, are very much at risk of having glaucoma or developing glaucoma. Uh, so it's better for them to go for screening, so that because that's the only way it can be detected. So if someone has been diagnosed to have glaucoma, the brothers, the sisters, parents are particularly at risk, the siblings and the offsprings of such a person. Uh, Person with severe myopia, high myopia, they have large pupil ratio, they are predisposed to developing glaucoma as well. Uh, Someone with elevated intraocular pressure is also at risk of developing glaucoma. Although, like I said earlier, it's also possible to have the so-called normal intraocular pressure and still have glaucoma that is equally blinding. Persons with antecedent history of trauma and use of steroid-containing eye drops, ancestry race um, is also a significant factor in, as a risk factor in glaucoma. Actually, glaucoma is more severe among Africans compared to Caucasians. For primary angle closure glaucoma, That's the type of glaucoma where the drainage of the eye is narrowed or closed. And the person has developed glaucoma. The increasing age is the risk factor. For this, it said that individuals usually above 55 years are much more at risk of developing primary glaucoma. For the primary open angle glaucoma, individuals above 40 years. What happens in primary pressure is that it's been said that as one advances in age, there is a decrease in the depth of the anterior chamber and the angle width, which punctures the drainage of the uh, fluid inside the eye, and the fluid accumulates and the pressure goes up, the angle closes or narrows. Well, persons with low blood pressure has been said to be at risk of glaucoma. This has to do with the palpation pressure of the eye, and the palpation pressure determines the blood flow to the optic nerve, especially the optic nerve curve. So, low blood pressure is a risk factor for glaucoma. But persons, individuals that are hypertensive, especially individuals that are hypertensive, especially when on antihypertensives, um, they can also be at risk of developing uh, glaucoma because hypertension can actually progress more in them, because what happens is the diurnal variation, the nocturnal dip that happens at night because of the steroids and all that uh, further lowers the BP. And together with the fact that they are taking their, if they take their hypertensives at night, what happens is lowers the BP at night, dips the palpation pressure of the head, and this puts them at risk of damage to the optic nerve curve because of the um, blood supply that reduces in them at night. So, race is a big factor in development of glaucoma. Africans have higher IOP. They have, they tend to have thinner cornea. The central cornea thickness is thinner among Africans. They tend to also have larger curve disc ratio. That's uh, the way the optic nerve exceeds the eyeball. If you, I'll show us a depiction of that, um, an image showing describing that curve disc ratio. The curve disc ratio is what we check in glaucoma when we do fundoscopy, and there is a part of the disc where called the rim. There is a part called the cup, and the fibers, nerve fiber of the retina, they pierce the lamina purpurea at that optic nerve head. And individuals with glaucoma, they tend to have larger curve disc ratio. So for Africans, compared to Caucasians and other races, they tend to have larger curve disc ratio, which also predisposes them to having glaucoma. Uh, Genetic basis of glaucoma has been well established. Um, the myosin gene has been said to be responsible for most of the primary open glaucomas, the GLC1A, the GLC1B, uh, for drug parks, for the primary aggressive glaucoma, the congenital glaucomas. All these, there are genes that have been identified, and hopefully in the future, there could be precision medicine and targeted therapy that can probably give us a cure for all these types of glaucoma. But for now, um, technology has not advanced to that level where we have gene therapy for glaucoma. But the good news is uh, people in inheriting these genes, even though they are at risk of glaucoma, if such a gene has been identified, there is hope in the future that targeted precision medicine will be available to them. Pseudo exfoliation, uh, people with pseudo exfoliation syndrome are also at risk of developing pseudo exfoliative glaucoma. Other risk factors which have not been, the level of evidence for this is not really high. You don't have that perhaps systematic review, meta-analysis, or randomized control trial for all this. But observational studies have shown that people that are obese, people that have diabetes mellitus, hypertensive, sickle cell disease, they are also have a form of risk of developing glaucoma compared to individuals without these non-communicable diseases. What's the burden of glaucoma? I'm not discussing it. Why is it important to health workers? The prevalence of glaucoma among the Caucasians is 2.1%. In the UK, it is about 2%. Uh, Amongst people aged 40 years and above, that is about 500,000 people. In Nigeria, the Nigeria National Blindness and Visual Impairment Survey, done between 2005 and 2007, showed that 5% of Nigerians, uh, the prevalence in Nigeria is about 5%, which is quite huge, high. That's about 1.7 million people. And at that survey, 20% were actually blind in both eyes. Uh, Globally, the estimated burden of glaucoma is about 60 million people in 2010. 2020, it was 65 million people, and it's projected that by 2040, the burden of glaucoma is going to shoot above 100 million people. That is huge, especially if you look at the economic impact and the impact of glaucoma on activities of daily living and the standard of living and quality of life for people. That's a lot of people to manage. Uh, Ethnicity, if you are bringing it home to Nigeria, that survey also showed that the uh, Igbos in Nigeria are particularly at risk of developing glaucoma compared to other ethnic groups in the country. But nationally in Nigeria, of what people that were diagnosed to have glaucoma, uh, only 5.6% of them were aware of their status. Clinical features of glaucoma. It is usually a painless disease, uh, gradual, progressive loss of vision, and that's where the name comes from, the silent thief of sight. So it's possible to, like this illustration on the right, uh, a seemingly normal eye, white sclera, cornea is clear, pupil is round, and everything seems normal and okay. What this person could be her neighbor, could be our colleagues in the office, could be our spouses, fathers, mothers, uh, anybody. And we are with them day in, day out. We have breakfast, lunch, we work with them in the office. It can also be our patients as well. Someone just walking in, being treated for malaria, or someone we are walking off for surgery, or a pregnant woman, health worker, politician, anybody in the society. What I'm trying to say is that it's not written on the face. It's just it is a silent thief. It's a pathology that exists beyond what we are seeing in the frontal part of the eye. It's what goes on. What we are seeing is just a tip of the iceberg. It affects the optic nerve ultimately, and the person will not have any complaints initially until it is quite advanced, and that's why it's labeled a silent thief. Uh, the unfortunate thing is that it causes an irreversible blindness. The visual loss is painless, usually gradual and progressive, and it is irreversible. So what happens? You rub your eyes, you are having some complaints, and at the end of the day, nothing. The eyes are white, and you are wondering, nothing, not even pain. So this is the tricky part. People that have glaucoma, they don't have usually have pain. Obviously, if you have red eye or you have pain in the eye, you tend to go to your doctor. You see your ophthalmologist, your optometrist, your ophthalmic nurse, or your family physician, and you complain to them. But here in glaucoma, nothing initially. But later, as it progresses, uh, a person with glaucoma starts bumping into objects. They start falling over objects on the ground. Because what happens is glaucoma, um, the visual loss in glaucoma starts on the outer edges of the vision. So it's possible to have glaucoma, even possible to have advanced glaucoma, and yet we are seeing well because we are focusing, we are looking straight. Glaucoma doesn't affect that until end stage. So what happens? It comes from the periphery, from the outer edges. Someone is losing 5% there, 10%, 20%, 30%, 40%. So it's becoming tunnel vision over time. So this is a good illustration. Uh, the picture on the far left, uh, with the same person, no eye disease. If you are looking at the person does not have pain, the eyes are white. Uh, the center picture shows this person with glaucoma. What is happening? This person looking straight ahead is still seeing, but to the side, the person with glaucoma will not see this. The person with glaucoma will not see the upper part of this image, will not see the lower part of this image, will not see to the right, to the left, we only see the center. And that's why glaucoma is called the black blindness. So the image on the far right here uh, shows number one cause of blindness worldwide, cataract. What happens is that there is like a veil across the vision of such a person. And if the person does surgery, the veil is removed, the person sees. But in glaucoma, the goal of the surgery is to help the drainage, reduce the intraocular pressure, try to modify the intraocular pressure to minimize damage to the optic marker. So the goal of the surgery in glaucoma ultimately is not to improve the vision because what has been damaged is irreversible. So this is another illustration depicting the visual loss through glaucoma. So, uh, so a normal person, someone without glaucoma, will see the whole extent of the visual field of this frame. To the right, to the left, above, down, the face, center, everything. But someone seeing this image that has glaucomatous disc or that has glaucoma and is advanced, you only see the center part. All this part will be missing. And this is what we call tunnel vision in ophthalmology. So how do we diagnose glaucoma? Well, we call it detection. We rarely use the word screening for glaucoma. Uh, Glaucoma does not really meet the criteria for screening of a pathology. The 10 youngest points or criteria to say, okay, this is a screenable disease. But we can still screen for glaucoma, only that it is very expensive and is not really advocated. So what is done is detection and diagnosis. So like I said, there's a structural damage that happens at the back of the eye. Uh, the optic nerve edge, where the optic nerve connects the eyeball to the brain. If you look at this illustration, this is the normal optic nerve head. We can see a pink disc here, and the cup is small. The cup is small, and if you look at the cup disc ratio, is like 0.3. By the time the cup is large and is taking up a lot of space due to glaucoma, there are characteristic disc findings, changes that the specialist will look out for when screening or when looking out for glaucoma. And those changes point to the fact that, oh, this person has features suggestive of glaucoma. So fundoscopy is not the only thing that will be done. There are other tests. So it's both structural damage and clinical features, attendant clinical effects of the structural damage that will be reflected in the visual field uh, that will make a specialist say, okay, this person has glaucoma. So this is a depiction of what the doctor will be looking out for when you do fundoscopy. So fundoscopy is the heart of looking into the back of the eye. Usually, when you come for your eye test, uh, the doctor will tell you, we need to check the back of the eye. So for people that use glasses, it's not just about routinely going to change your glasses. So the next time you're going to change your glasses, tell the doctor, are you going to perform a fundoscopy on me? Well, it is important. Well, you can't see the back of the eye with your naked eye. The eye has to be dilated sometimes, or you can use a direct ophthalmoscope, which is not advisable these days of coronavirus. So, what will be done usually is to dilate the eye, and a lens will be used to visualize the back of the eye. And if the doctor, your specialist, if they note that the structural changes at the back of the eye are suggestive of glaucoma, then further tests will be performed. Then you'll be counseled on the next step. Uh, Intraocular pressure measurement is also important in detection of glaucoma. Like I said, it's a major risk factor. In fact, it's the only modifiable risk factor that we know. Most of the treatments available for glaucoma now are directed towards reduction of intraocular pressure. So what happens is when you go to for your eye check, they perform a fundoscopy, check the disc, they do an intraocular pressure measurement. If it's elevated, ordinarily above 24, uh, they will tell you, oh, this pressure is suspect. Wow, or you have a substitute disc, or your pressure is high, then the doctor will counsel you particularly on what to do next, on the fact that they are suspecting glaucoma and what glaucoma is all about, what you need to do, what other tests has to be performed, and if it's actually very, very high, um, uh, eye drops can be given, treatment can be instituted immediately. So it's also important. The clinical aspect, what the patient will report, like I said, is visual field loss. The person with glaucoma will not really complain initially of visual loss. They are going to see very well. They are still going to drive. They are going to read. Vision is going to be perfect when you test it. But if you perform a central visual field, the periphery, the edges, the outer edges of the vision is going to show uh, some defects uh, that are characteristics of glaucoma. And such defects, if suggestive of glaucoma, will be a pointer to treatment and the extent of the damage. So without the visual field, you can't really say, okay, this is a mild glaucoma, moderate glaucoma, or severe glaucoma. All these have implications on treatment. If available, optical coherence tomography, it can also be done, especially in borderline cases. And when your specialist is telling you, okay, you are a glaucoma suspect, there is structural damage in the disc, the pressure is not too high, should we start treatment or not? Uh, they usually suggest that you go for optical coherence tomography, such that uh, you can have a baseline and you can repeat it, you can compare, and you can make decision on whether to start treatment or not. And modern OCT also has the disc damage likelihood score that can come with it. And if your score is 4, 5, they will tell you that, oh, you are at risk of progressing, they can start treatment. If it's above 5, they are definitely going to start treatment for you. But if it's 3 and below, okay, they will say, okay, you're still within the normal. Even though you are a suspect, you are just going to check you routinely. They are not going to start treatment. So optical coherence sonography is a good test that can be done. Then for the two major types of glaucoma, the only way to differentiate them is to do a gonoscopy. A gonoscopy is an art of checking the angle of the eye. So whether the angle is narrow or closed. If the angle is open and person has glaucoma, it's called open angle glaucoma. If the angle is narrow or closed, it's called angle glaucoma. And the only way to know that is to perform a gonoscopy. And this is usually done by specialists. So it is necessary uh, when you go for your eye test. It's not just about changing the glasses or getting eye drops. Um, a colonoscopy may be requested and can be performed in clinic. So, what are the treatment options available for glaucoma? Usually eye drops. Like I said, the only treatment is reduction in intraocular pressure, which is what is the only modifiable risk factors we know. What happens with intraocular with eye drops? Uh, with reduction in intraocular pressure is like person diagnosed with glaucoma tend to use the eye drops um, for life most of the time. Um, so it is difficult. I must tell you, especially if you have to combine 1, 2, 3 drugs. Uh, that's where we come in as health workers. It is our responsibility to ensure compliance. I must tell you, even for health workers, it's not easy to take drugs, especially if you have to take drugs 3, 4 times a day. You have to set alarm, you need family support. So it's a big task for the person or the individual. Or surgical options are also available for glaucoma treatment, mostly trabeculectomy, um, which is creating a fistula and alternate pathway or drainage for the aqueous in the eye, so that a bleb is created in the under the conjunctiva, usually where it is not seen, they need to cover it, and excess fluid in the eye can drain outside through that alternate channel. There are newer surgical techniques, mostly modification of trabeculectomy to minimize the complications. Laser treatment is also available for treatment of glaucoma, uh, especially for the angle closure glaucoma. But the summary of this is that uh, there is no cure for now. Um, so the earlier we detect the glaucoma and start the treatment, so that we maintain the vision available for the individual, is the goal of treatment. So we cannot reverse the lost vision, even with all these treatment. Now, treatment can be expensive as well, especially where you have no insurance or health coverage. So, what health workers should know about glaucoma? It is a public health problem. It is the second leading cause of blindness worldwide after cataract. Primary open-angle glaucoma has a high prevalence among Africans than Caucasians. Primary open-angle glaucoma has an early onset it also progresses more rapidly among Africans than Caucasians. So we as health workers in Africa, we need to understand this. It's glaucoma is among us, and it can affect any of us. The fact that your eyes are white, or the fact that you are not having complaints now, or that your vision is seemingly perfect, doesn't mean nothing is going on behind. And why should we take glaucoma seriously? The awareness, the knowledge about glaucoma is quite low in our environment. 5%, even amongst people that have glaucoma, only 5% are aware. So we have an army of people there. 95% are not even aware that they have blinding eye disease. So that if they are developing glaucoma in their middle age, by the time they are transitioning to becoming elders in society, or by the time uh, they are going blind in numbers, if people, the working class age group, are not even aware they have a pathology going on. So it's a big problem for us, not just eye specialists, but for all the health workers, because the eye is the window to the soul. There is no point seeing a patient, uh, a pregnant woman, someone with malaria, someone with trauma to the bone from injury, accident, someone with acute abdomen, and you manage the patient beautifully well, you are discharging the patient, only for the patient to come back to your clinic blind, and you have seen the patient. Or not just even the patient, it is a crime for you as a doctor not to know about glaucoma. You can, you are a doctor and you have a family member that is going blind from glaucoma. You have a daughter, a son, sibling, a spouse. It's I cannot imagine the kind of pain that someone under your nose um, is having glaucoma, and the glaucoma has been there for 10, 5, 20 years. Simply because it doesn't show any symptoms. You are not doing anything about it because you yourself, as a health worker, you don't have enough uh, knowledge or actionable points about glaucoma. So this is a responsibility for all of us. Uh, we just need to up our game. We, we can't leave this to the high health workers alone. All hands must be on deck. We need to have posters in our consulting rooms. We need to tell our patients about glaucoma. Just ask them, do you know about the silent thief of sight? We are treating someone for infertility. Glaucoma does not discriminate like that. Someone with seemingly uh, harmless lupus condition can have glaucoma. And what you have to do is to tell that patient, tell that your colleague that have you been to your eye doctor this year? Do you know that glaucoma is the second leading cause of blindness worldwide? Are you aware that glaucoma has a high prevalence among Africans? It has an earlier onset. It has a more severe course. So we need to create that awareness, not just for us, not just for our patients, not just for our family members, but for the benefit of the society. Uh, we also need to take glaucoma seriously because by lowering the intraocular pressure, that modifiable risk factor, you can preserve the vision, as it were. Even though you cannot reverse the lost vision, but the vision, the existing vision the patient is bringing, or that you have, or that I have, I can preserve that by taking measures, by going for treatment early to lower the intraocular pressure. In Nigeria, 90% of the patients we see as ophthalmologists that we are diagnosing as glaucoma have severe disease. There is this epidemic of late diagnosis, and the only way to tackle this is to create awareness. When people are aware that glaucoma is here to stay and that treatment is available, they will seek for detection or screening, they go for medical check, and you can avoid late diagnosis. Because at late presentation, we are dealing with irreversible visual loss. So Africans are very much at risk of visual loss, including health workers from glaucoma. Igbos from Igbos in Nigeria, they tend to have more blindness from glaucoma. Male gender, unmarried individuals, single, probably because there is a public health aspect to this, in the sense that if you are married, you have a partner that will encourage you to go for screening, for tests, and if you have doctor's appointment, you have someone that can remind you, someone that will follow up. If you have been diagnosed to have glaucoma, you are on eye drops, you have a partner that can help you administer your medications. If you have to go for glaucoma, so you have someone that can. Uh, so there is that social support for married compared to unmarried. Uh, Female too, single females with glaucoma are likely to go blind. So uh, poverty is also a factor in progression and eventual blindness from glaucoma. Uh, it's where there is no health insurance or health coverage where people have to pay out of the pocket. Uh, the eye drops can be expensive. Uh, the lower form of surgical intervention, the tube surgeries, can also be expensive. Also, the lifelong use of medications, follow up, the test investigations. So, uh, deprivation is a major factor. Access is a major factor. What are the factors that will accelerate the progression of glaucoma? Individuals with elevated intraocular pressure, late presentation, lack of treatment, poor access to treatment, low socioeconomic status, level of education. As per the level of education, Nigeria could be reversed. Where public health wise, individuals with the illiterates or lower level of education tend to have poor health seeking behavior. Hence, uh, even when they are diagnosed to have glaucoma, um, they can tend to believe in traditional medicine or tend to have customary or cultural influence that can prevent them from using the prescribed medication. But in Nigeria, I've seen cases of professors using local medication uh, for high disease, um, urine, all sorts of things that will worsen the condition. Uh, so the important thing here is creating awareness with proper education, information, facts about glaucoma, and putting it out there for people. So, what's the role of health workers in prevention of blindness from glaucoma? Um, we are Sorosuke generation. So health workers, we need to say it out loud. We need to announce this. We need to, let our patient know. Let's call a family meeting. You know, at every opportunity we have, we should tell people about glaucoma. So we create awareness in the community. Let's just facilitate opportunistic screening. And if a person has been diagnosed with glaucoma, first degree relatives should be referred for screening. So if you are coming across a patient, the person is not even coming for eye complaints and it's in front of you in your clinic, and the patient has uh, one form of visual impairment, ask them questions about glaucoma. Tell them to go for screening. If we are seeing a patient using eye drops, encourage them to use it judiciously. Compliance is very key. So it's not just having the eye drops, they need to apply, they need to lower the intraocular pressure. So if someone is asking you questions about glaucoma, um, just need to tell them it's a serious disease causing irreversible blindness. It can affect anyone, irrespective of the presenting symptoms or illness. They need to have regular eye examination by specialists, especially when they are above age 40. Uh, there is need for early detection and treatment is very important. There is need for yearly eye examination. So, what can we do to prevent glaucoma blindness? Opportunistic screening. We cannot screen everybody the way we screen for uh, diabetic retinopathy. Uh, People with diabetes, okay, go for your eye check. Cervical cancer, young females, you know, HIV, tell people if you are high risk or if you are getting married, that can also be adopted. Opportunity screening. You cannot say, okay, everybody in the community should go to the eye clinic. But at certain points, we all have that opportunity to have our eyes checked. People approaching age 40 or people above 40, if you're having difficulties with reading or what we call presbyopia, visually, and uh, your eyes cannot really accommodate again, you are going for your eye check. You want your optometrist or your ophthalmic nurse practitioner or your ophthalmologist to change your glasses for you. So at the same time, let them know it's an opportunity to check for glaucoma. All they have to do is to do fundoscopy, check intraocular pressure, and they can send it to the ophthalmologist for further check. Um, at the point of renewal of driver's license, eye test should be done, and screening for glaucoma can be assessed as well. Um, at every point, we are asked to do a pre-impairment evaluation. We shouldn't beg our doctors to sign the form for us of our children trying to transition from one level of schooling to another. When it comes to eye check, let them do glaucoma screening for them as well. But ultimately, there is what we call integrated glaucoma service, where the screening will be done, bronchoscopy is done, fundoscopy is done, and treatment can be assessed. And this is available usually at secondary centers and tertiary centers. So it is all you have to do is to request or refer a patient to an ophthalmologist or an optometrist. They will get the eye checked for glaucoma. So it's recommended that people aged 40 years and above should have regular eye check. Um, High risk groups should also have regular eye check. People that have had trauma in the past, people that are using steroid containing eye drops, um, people whose relatives or family members have been diagnosed to have glaucoma should all have regular eye examination. So, what are the take-home messages? Delay in obtaining the correct treatment increases the risk of losing even more vision. Uh, Glaucoma doesn't cause sudden loss of vision as such. So if someone has been diagnosed to have glaucoma and they still have fairly good vision, that can be preserved to their old age, and treatment is available. So there is no need to hesitate. Delay in obtaining the correct treatment increases the risk of losing even more vision. So there's need for regular eye check. Report to the nearest eye clinic urgently to be examined. If you think a relative may have glaucoma, advise them to do the same. And this is the end of this presentation. It's been a privilege to give this talk. I hope you have enjoyed it. The high service indeed. Thank you.
Thank you very much, Dr. Adewale Timothy, for your wonderful presentation. It's been very enlightening. We'll now go to the questions, but before we do that, we would like to run a poll briefly to just ascertain the knowledge of healthcare workers, their awareness about glaucoma. So it's showing now. You could just so while we are doing that, can we see the quiz? Yeah, okay, good. Very good. So it just has about five, how many questions? We have about 7 questions. So let's all attempt it. You can't. Okay, so we're just allowing for time to answer the questions. It's 7 questions. Okay, so I'm just trying to give some time for people to answer the quiz. I'm sure we'll all ace this, given the very detailed lecture we just received. Don't forget to click on submit when you're done with the quiz. So we'll be playing a glaucoma video, um, um, just to enlighten us some more. So. It's a patient's interview, actually, a patient's experience. So just stay tuned for that. Okay, well, I guess we're having some technical issues here. I'll just go ahead to read some of the questions. The first question is from Dr. Chinedu Okoli. So this to the presenter. He says, for people who have been screened in the past and told they don't have glaucoma, how frequent should they be rescreened? So Dr. Deole, would you?
Thank you, Dr. Koli, for the question. Uh, Usually, it depends on the findings at that initial examination. And so, what happens is such a category of persons that have been told that uh, their high check or the examination was free of glaucoma uh, should not just go to sleep as such. Uh, because, like I said, there are risk factors, and glaucoma does not develop in one day. It develops over time. So it's possible that at this point in time, or at the point the examination was done, the risk factors uh, that could predispose such a person to develop glaucoma were not there. And for instance, if a person has been using steroids or commences steroids use after that examination, the risk is now higher, and so the person should return for evaluation again. If the person has a family history of glaucoma, for instance, that is a very strong risk factor. And such a person will not just go to bed. I'm sure the doctor will not tell the person not to come back. But the person will be told to come every year, at least once a year. Um, if the person has suspicious disc or suspicious findings in the visual field test, but those evidence or those findings are not strong enough to label the person as uh, being glaucomatous, and the person will be diagnosed to be a glaucoma suspect, and the person will be asked to do further test and bring the result, usually every 6 months, uh, visual field, or every year, so that at the end of the day, we are going to have a trend analysis of the visual field. We can say in year 2020, this was the visual field. In 2021, this is the visual field. In 26 months after, so you can have comparison of three visual fields, and you can see progression. If there is still no progression, the person will still be told, okay, come back after 1 year or after 6 months. Um, but peradventure, uh, a defect was found in one of the tests, then the frequency of visits will be shorter for such an individual. Um, if someone has had trauma, for instance, a blunt ocular trauma, that's what we call angle recession glaucoma. This can develop over 10 years as well. So the level of, so if you are seeing the person, let's say 2 years, 3 years after the trauma, the person doesn't have glaucoma, but the person can have 30 signs of trauma in that eye. And I said trauma is a risk factor for developing glaucoma. So such a person will still be told, oh, you have that risk factor, the risk factor has not gone. Um, the scarring that can happen in the eye can lead to glaucoma. So you still need to come in every year for your examination. So in essence, people above 40 years, if you are doing your test or you are involved in opportunistic screening, as it were, probably pre-employment at the point of changing driver's license, uh, such individuals being told at that point that there was no glaucoma should not just go and rest. They should still check. You are above 40 every year, go for your eye check. It will only take some few hours. It's better, like what they say, prevention is better than cure. I hope that answers that question.
Thank you very much, Dr. Adewale. There are more questions here. There are more questions here. There's another question from Ibrahim. He says, are there other factors responsible for elevated IOP apart from glaucoma? I'll repeat the question. Are there other factors responsible for elevated IOP apart from glaucoma? Then also another question from Dr. Ibrahim. And it says, at what point can IOP pose a problem?
Yeah, thank you, Dr. Ibrahim, for the question. Like I said, okay. Yeah, thank you, Dr. Ibrahim, for that question. Like I said earlier, glaucoma is a group of diseases. It's not just an entity. It's 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 a complex pathology, and what we know so far is that intraocular pressure is a modifiable risk factor. Is what we now target in our treatment for glaucoma or management of glaucoma. So, are there other things in the eye that can cause elevated intraocular pressure? Yes. So, it is possible to have elevated intraocular pressure without having glaucoma, because to diagnose glaucoma, you need certain criteria to be present. So it's not just having the intraocular pressure that is elevated. It should be elevated enough over time to cause structural damage to the optic nerve. So we are not talking about optic neuropathy. So that endpoint is what defines it. It's what makes it glaucoma. So it's not just having that optic neuropathy, because there are other diseases that can cause optic neuropathy, but you must have characteristic optic neuropathy. That's the structural damage you see at the optic nerve head that are peculiar to glaucoma. So having that elevated intraocular pressure would go along as a risk factor to causing optic neuropathy. So, and having that optic neuropathy, what are the effects, the attendant effects on the visual field of the person? That's why we need to do other tests, the visual field test, to assess the damage to what the person is seeing or the person is reporting. So, and what kind of defects are we seeing? are the defects specific for glaucoma as well. So that's how we made the diagnosis of glaucoma. So it's also possible to have um, elevated intraocular pressure without having glaucoma. So it's called ocular hypertension. So, but ocular hypertension can also progress. People that have ocular hypertension can progress to develop glaucoma, primary ocular glaucoma in the future, meaning that they will still need to be monitored and examined. Um, if you have an inflammation taking place in the eye, an anterior uveitis, for instance, the intraocular pressure can also go up. The person does not have glaucoma, but IOP can be elevated. But all these things are also risk factors. For that's why I said glaucoma is a complex disease. The fact that intraocular pressure is going up means that there is a mechanical effect. They're being transmitted to the optic nerve head and the optic nerve, which can lead to an optic neuropathy and eventually that end point of irreversible visual loss of glaucoma. Thank you, Dr. Ibrahim.
All right, thank you. Then to the last question. The last question is from Andrew Iyaji. And he says there have been reports and verifiable too of some reversal of IOP. I'm not sure if he meant reversal of copying. Oh, well, he says there have been reports and verifiable too of some reversal of IOP and improvement of sight in some people using oral antioxidant supplements. Have you come across such cases? Is it dependent on the cause or risk factor? And another question from this same person, it says, does reading long and from electronic screens and sleep deprivation predispose to increase in intraocular pressure and perhaps glaucoma?
Okay, thank you, Andrew. Thank you, Andrew, for the question. As far as glaucoma is concerned, the blindness is irreversible for now. As far as medical knowledge or research, um, where we are today in science of glaucoma, the advances, we've not been able to find a way to clinically reverse the pathology, that effect on the optic nerve. Because that's the end point, that's where the issue is. We also understand that optic nerve, we are just seeing the tip of the iceberg behind the eye. It's just part of the visual pathway, the afferent part of the visual pathway, the what goes to the brain. So it's a whole lot of work going on in glaucoma research, and hopefully in the future uh, we can find a cure or targeted therapy. Like I said earlier, work is going on precision medicine, especially now that genes have been identified for specific glaucomatous types, and such targeted precision medicine can will probably be available in the future. But as for what you said that antioxidants reversing coping or blindness, well, there are drugs, several drugs that have been tested for glaucoma, newer medication. In fact, so several medications are coming up every day, and uh, so many of them, the neuroprotective drugs, neuroregenerate for neurodegeneration, and but none of them so far has been proven in a randomized control trial um, to be a cure, or that can reverse, or that has successfully reversed the damage seen in glaucoma so far. But like you said, there are so many trials going on uh, right now In fact, one of the latest trial in Germany is the use of steroids, high dose steroids, to treat glaucoma, whether it can reverse the damage. But all these trials, the results has not been encouraging. There is no evidence um, scientifically to back such claims. What's the question?
Okay. The second question: does reading long and from electronic screens and sleep deprivation predispose to increased intraocular pressure and perhaps glaucoma?
Well, stress basically is not good for anybody or any organ in the body. Prolonged reading is a form of stress, but is there a risk factor for development of glaucoma? No. Um, well, is there a risk for other issues with the eye? Yes. Uh, Maybe if prolonged reading can lead to dry eye syndrome, because there's tendency not to blink frequently, and the spread of tear film layer over the eye. Uh, but one thing I said during the presentation was people with high myopia, severe myopia, normally they tend to be short-sighted. They need glasses for distant vision. Uh, so such people, they have large disc, and so what we can say, if you have high myopia, people that are used to have thick lenses, they are at risk of developing glaucoma, so they need to uh, go for eye check.
Yeah. Thank you very much, Dr. Adewale. So more questions have been coming in.
Okay.
Okay, these
Two questions
two
from
questions
an
from
anonymous
anonymous
attendee.
attendee.
First is,
First is
there are
there are
sponsored
sponsored
ads
ads
seen every
seen
day
every day
on some
on some
medications
medication
used to cure
to cure
glaucoma.
glaucoma. What is the association or forum doing to mitigate against the damage this is causing to many? Have they verified any of these claims? That question is actually to YOF. Then this second comment and question is, thank you for your presentation, sir. I'm concerned about the fact that glaucoma needs urgent attention vis-a-vis how soon individuals can be seen in the hospital. The patient load is high in some hospitals, and screening at the initial appointment and follow-up appointments can take months, within which the disease would have progressed irreversibly. So how can such patients be helped? Thank you. Maybe you can start with the second question about the prolonged screening time, waiting time. Uh, then we can, I think Dr. Ebukun can answer the question on what the association is doing to mitigate against the damage from sponsored ads.
Thank you for that question. Uh, Glaucoma is a problem globally, worldwide. Um, the truth of the matter is, anywhere in the world, glaucoma clinics are very, very um, intense, prolonged. Um, Usually, it's I won't really super crowded, but it's a testament to the fact that disease has a high prevalence, and the fact that patients are yearning for cure, and there is no cure. So, someone that has been diagnosed to have glaucoma tend to come to clinic often because it's difficult to lose one sight. They tend to come around, and their expectations are very high. So, what happens is they don't want to miss the appointment, and you have additional load, newly diagnosed coming in, you have first degree relatives coming in for screening, and the resources are limited. The doctors, the facilities, the infrastructure, the space is not expanding. So what I'm saying is that the workload is overwhelming for glaucomatologists, for ophthalmologists, um, globally. It's not just a problem with Nigeria or Africa. So what we need to do is to think outside the box and find a way at community diagnosis of glaucoma, which is difficult. And like I said, glaucoma did not really meet or does not really meet the criteria for screening for a disease as such, because to do community diagnosis is very expensive. And such test that has been recommended, the fundoscopy, the intraocular pressure, the visual fields, you need to diagnose glaucoma correctly. You can really take them to the community as such. It should be expensive. So you can't really do mass screening. So what we are advocating for is opportunistic screening. So you don't have to wait till there is complaints or there's blindness or there's bumping into objects or you are falling over objects. So what we are advocating now is opportunistic screening and creating awareness such that at every point in people's lives, um, the point of moving from secondary school to university, primary school to secondary school, um, pre-employment evaluation and screening, we do pockets of individual screenings like that, such that all of us are not coming to eye clinic at the same time. So at various points in our lives, we will have done a proper eye check and they will have told us this is what is happening at the back of your eye. You are a glaucoma suspect, you are not a glaucoma suspect, and as such, we are going to reduce the pressure we have on our facilities. And medical electronic medical record system should be instituted across board as well, where proper staggered appointments can be given to patients. Patients are not all coming at the same time. There is no way you have 100 patients coming to a clinic at the same time, 8 a.m., 9 a.m. There should be staggered, timely appointments across board. Thank you.
Thank you very much, Dr. Adewale. Dr. Ibukun.
Okay, thank you very much for the question on sponsored ads about drugs touted as cure for glaucoma. This is really a menace for a disease we know really has to cure. And I'll say that this is something the forum will put in mind. We'll liaise with our mother association, the Ophthalmological Society of Nigeria, to engage stakeholders, regulatory bodies such as NAFDAC, to see to this and see how it can be curbed. Thank you very much.
Thank you very much, Dr. Ibukun. The last question is requires a short answer. It's from Dr. Chinedu Okoli. And it says, can one have glaucoma without a rise in intraocular pressure? Dr. Adewale.
Thank you, Dr. Chinedu, for that question. Yes, it is possible to have glaucoma without elevated intraocular pressure. There is an entity called normal tension glaucoma, which I described earlier, and that's where we have moved away from the concept of normal intraocular pressure. So if a client or a patient comes to me now and I measure the intraocular pressure, I will not tell the person that this is your intraocular pressure, it is normal, it is within the normal range. Rather, I will tell the person that, oh, target intraocular pressure for your eyes based on my examination, based on the structural damage or the visual field findings I've seen, should be this or this or this. Sometimes it's possible to have intraocular pressure of 10 and the person is going blind. And it's also possible to have intraocular pressure of 21 and the person doesn't have glaucoma. So, but there's an entity called normal tension glaucoma, NTG. So it's possible to have normal intraocular pressure and develop glaucoma as well. Thank you.
Thank you very much. Dr. Adewale. All right, so time is fast spent. We can see the result of the poll has been projected already, and we can see that it's been a very beneficial interactive session. Majority of us answered the questions correctly. In fact, everybody is aware that glaucoma causes irreversible visual loss. Almost everybody knows that it can be asymptomatic. Majority of us now know that a risk factor for developing glaucoma, it's a family history of glaucoma. We all know that it's the silent thief of sight. And then, yes, in fact, everybody also answered correctly on the treatment, saying it can be medical or surgical. So I would like to thank everybody for participating in this interactive session. I want to call on Dr. Cyril to give us a closing remark, after which we'll be playing a video on patient's experience from a glaucoma patient, actually, a patient's first-hand experience. Thank you very much. So over to you, Dr. Cyril.
Thank you very much, Dr. Languju. I want to thank you, Dr. for the presentation, and we thank you for the time. We thank you for the effort you've given to kickstart our World Glaucoma Week for this year. It's our hope that every health worker here has benefited from this presentation and can take the message of glaucoma to your patients and loved ones outside this forum. The World Glaucoma Week has kickstarted officially for the YOF. We have numerous live radio programs and TV programs built for the week. On Wednesday, the International Agency for Prevention of Blindness will be launching the Sub-Saharan Glaucoma Toolkit, a toolkit that's to be used for management of glaucoma, and it's hoped will revolutionize the care of glaucoma and make it more easier to care for glaucoma in Sub-Saharan Africa. And so a webinar will be on that by 12 noon. On Friday, there was going to be a Facebook and Instagram live session for glaucoma for the public. And please would endeavor that we try to join the program to learn more about glaucoma. And then on Saturday, our CME-based webinar session on glaucoma will hold by 10 a.m. There are CME points available. Please let's get registered and attend the program. And while we attend the WIO programs, I also want to ask us to participate fully in our center programs and take the gospel of glaucoma to everybody in the streets. I want to thank Dr. Ibukun Folahan for her role in chairing this World Glaucoma Week, and your team. You have done more than expected. I want to thank you very much and ask that we keep supporting the YOF. And thank you very much once again. And let's watch this video. It's going to help us with our education on glaucoma for the public. Thank you very much.
Thank you, Dr. Cyril. So over to the video.
My name is Evangelist Samuel Ola, JP. By the time I noticed that I have glaucoma, was around 2006. Well, by the time I was told that glaucoma was the one affecting my eyes, I feel so bad. Even I was asking myself, why me? Why me now? I don't feel comfortable. Since that time, I've been receiving treatment at UCH Ibadan. And they told me by that time that I will be managing it. I've been managing it since then. And since that time, I've been managing to move to anywhere by myself. I thought it will be by operation, but they say with my own, they say I must continue to manage it with eye drops. And I have about 2 kinds of eye drops that I am using now. For those, whoever, I will even advise almost everybody that they should check the situation of their eyes at least once in a year. Whether you have glaucoma, you don't have glaucoma, whatever disease it may be, go and check your eyes to know the situation of your eyes. But by the time they diagnose that you have glaucoma, please adhere, dance to the tune of the doctor, and continue to use your medicine. If you are using eye drop, you can live with that glaucoma as long as you are living, and you will continue to see, to move about by yourself. But if you think somebody can perform miracle by putting another thing in your eyes, they may say in Yoruba, tiro, and some other medicine, apart from eye drops, not diagnosed by the doctors. It's as if you are dragging yourself to blindness, total blindness. My advice to you is to follow strictly whatever your doctor tells you to do.
So thank you very much. This will be the end of the interactive session. Thank you all for tuning in. So looking forward to seeing you at the other activities scheduled for the World Glaucoma Week. Goodbye, everybody.